will be recording this next session. A few housekeeping announcements first before we introduce our panel presenters. So in addition, I want to remind everyone, if you're just signing on, be sure to claim your CME credit by signing in through Cloud CME mobile app. Text 3180X to 844-420-1171. For all attendees, I want to remind you to mute your microphone, turn off your video, and pin our guests or presenters so that you will be able to see them on the screen. With that, I am happy to welcome three of our physicians in the cancer program, Dr. Amie Hopp, Dr. Martin Luchtefeld, and Dr. Paul Wright. We will have questions for the panelists and go one by one. We'll pose those on the screen, and we will save other questions until the end of the panel presentation for additional questions. I'd like to ask each of the physician panelists to briefly introduce yourselves, and then we'll start with the first question. Starting with Dr. Hopp. Dr. Hopp, you may be on mute. Could you unmute yourself, please?
Can you hear me now? Sorry about that.
Yes, we can hear you now. Thank you.
Okay. Good afternoon. I'm Amie Hopp. I'm one of the breast surgeons here at Lemon Holton. I've been in practice for just over 4 years. In the first 3 years, I was doing general surgery with a breast focus, and I've been here at Lemon Holton doing primarily breast for the last 1.5 years.
Thank you, Dr. Hopp. Dr. Luchtefeld.
Hi, Marty Luchtefeld. I'm a colorectal surgeon. That's really all I've done my entire career, and you don't want to know how long I've done this. It's been a long time.
All right, thank you. And Dr. Wright.
Hi, I'm Paul Wright. I'm a surgical oncologist and trained here at the same time as Dr. Hopp, and spent some time at the University of Pittsburgh before I came back here, where I've been for the last 4 years.
Thank you. We'll advance to our first question for all of you. So, like each of you in your respected areas, to talk about some of the common side effects that patients may experience both during and after treatment. And we don't need to take this in any particular order.
Well, I can maybe start with that. And first, I'm going to say that even though colorectal surgery may seem like a sort of a homogeneous treatment area, actually the complications and the side effects are very different for colon surgery versus rectal surgery. Colon surgery in some ways is a little bit more straightforward, and typically the treatment consists of surgery first, followed by chemotherapy if needed. Rectal cancer surgery, on the other hand, is considerably more complex, and it's changing all the time. And in addition to the surgery, involves many times radiation and chemotherapy before the surgery. So the side effects are very, very different for both of those surgeries. And I could spend all day talking about this, so I'll be relatively brief with both of them. But for colon surgery, and here we're talking about not doing anything in the rectal area, but for colon surgery, the one thing that you might anticipate in terms of a side effect immediately following surgery is some change in bowel habits. The changes tend to be more pronounced when you take out the right side of the colon. That tends to sometimes lead to diarrhea, and typically that can be relatively easily treated. But other portions of the colon, there may be just some sort of known redundancy in the bowel. So when you take out other sections of the bowel, you may come out of it with essentially the same kind of bowel habits as you had before. With rectal cancer, it's a very different situation, and here the side effects that are common are many times related to radiation and chemotherapy. And part of the rectum's function is sort of a reservoir. And so when we do radiation, when we do chemotherapy, when we do surgery, all of these tend to affect that reservoir function. And all of these things tend to effectively make the reservoir smaller. And so one of the most common things after rectal cancer surgery is that because the reservoir is smaller, you have more frequent bowel movements, and you may not empty it as well, which is certainly, it's not a life-threatening side effect, but it can be, very intensely irritating to the patients that's having to go through this. And again, we could talk all day about that topic, so I'll just stop right there.
Dr. Hopp, would you like to go next? Could you unmute yourself, Dr. Hopp?
Yeah, I agree with Dr. Luchtefeld. There's a lot of ways that we can approach, just like in his field, a lot of ways that we can approach breast cancer surgery and breast cancer, and for many women, that's going to include some form of systemic therapy, possibly radiation and surgery, and that can definitely impact the side effects that they have. But the surgical side effects depend greatly on what type of surgery that they have on their breast and on their axillary lymph nodes. And for women that have a lumpectomy, usually the healing time and recovery time is straightforward. Many of them, though, can have issues with scarring or tenderness that can be prolonged. If there's more extensive breast surgery like a mastectomy, more common things are decreased range of motion, tightness across their scars, possibly nerve pain. Those are all things that we see commonly. That also can be complicated by a reconstruction process if they move forward with that. There are many different types of reconstruction, and their side effects can vary based on the type of reconstructive surgery that they have. But many of the common things are similar to a mastectomy on its own, where range of motion might need to be addressed, muscle tightness, things that are musculoskeletal in nature. The rest of the side effects usually come from the axillary surgery itself, and we try to minimize that as much as possible in the treatment of cancer. So only removing the lymph nodes that we need to in order to make treatment decisions is extremely important. The main reason being to try to avoid the side effect of lymphedema. And lymphedema itself, especially in patients where we take minimal nodes, is luckily quite rare, but we do like to make patients aware of it. If we have to do a larger axillary dissection or remove lymph nodes, the rate of that goes up, and our overall sensitivity to issues that might be related to that is definitely heightened. So even though those are lymphedema is less common, it's probably the most common thing on a patient's radar, because if that were to occur, it generally affects them lifelong. So it's something women are very aware of, and a lot of providers are very aware of.
Thank you, Dr. Hopp. We'll go to Dr. Wright next.
Yeah, I think my answer is even more complex than Dr. Luchterfeld's and Dr. Hopp's, because my practice is very broad, and so I deal with sort of more minor procedures for things like melanoma and breast cancer, to very complex intra-abdominal operations for the liver and other areas, and so it kind of spans I would say the riskiness of surgery. For the more minor things, like Dr. Hopp was saying, things that are across procedure types are incisional pain, risk of infection, fluid collections, and things like that underneath the skin. And those are really across any type of surgery. And so we always talk about those things as sort of a baseline. Melanoma also, we deal with lymph node surgery. Similarly to Dr. Hopp, as she was mentioning in breast cancer, there's been a transition to doing less extensive lymph node surgery the last few years, and we've got some great evidence to show that patients do just as well if you remove fewer rather than many lymph nodes. And so we've changed some of our protocols from that standpoint for melanoma. And then as far as some of the intra-abdominal cases, these are very, very big operations. They're potentially life-threatening. And so the type of complications depends a lot on what area within the body that we're doing surgery on. The liver is a very risky organ. The pancreas is a very risky organ to deal with. And those each kind of have their own set of side effects, in addition to dealing with the stomach and intestines, where we always worry about whenever we're making a new connection. Dr. Luchtefeld makes lots of new connections, and so we're both used to trying to get that to heal in well and get patients set up for that to heal well. But those are a lot of the things that we manage in the hospital. Long-term things are just sort of the general fatigue and deconditioning that can happen with a big abdominal operation, and I'm usually giving patients about 4 to 6 weeks as far as expectations for what it might take to recover from something like that.
Thank you, Dr. Wright. We'll move on now to our next set of questions for the panelists. Can you talk about self-administered management techniques that patients should consider and prepare for to manage any of the side effects that you mentioned? And then also talk about any prevention to reduce the risk of side effects. Start.
I can maybe start, and I'm going to emphasize more the prevention to reduce the risk of side effects. And here I'm including in this the risk of side effects and complications, not necessarily just side effects. And here, one of the things that we have discovered in surgery, it seems self-evident now in retrospect, but getting someone ready for surgery is just as important as doing the surgery well. There are things that I think in the past we didn't emphasize enough in terms of getting patients ready for surgery. We talk about a post-op rehabilitation, and now the term is pre-op rehabilitation and getting patients ready for surgery. And when you're talking about a big surgery with a lot of risk for complications and side effects, that is very, very important. There's a number of things that are very high on this list. Maybe number one is if you're a smoker, quit smoking. And we have not done as good of a job as we could in the past on that particular aspect. I think we now have more support in terms of being able to send people away to get tobacco cessation. And especially if you're operating on a cancer, you don't always have 3 to 4 months to work on this. So it has to be a pretty quick turnaround. In addition, just, simple things like having a patient that's relatively non-ambulatory to get them up and moving and walking before surgery. We also work on weight loss if there's time to do that, because that in a significant amount of obesity certainly increases the risk of all of our complications and side effects. The other things that we can work on, but again, we're sometimes, if we're operating on cancer or a relatively urgent situation, some of the things that we're stuck with not having enough time for are things like correcting anemia. I already mentioned the ambulation and the smoking, things like that. And then in terms of other things that we do is if you follow all the recommendations for the nutritional supplements and things like that before surgery, this will go a long way to reduce the risk of side effects and complications after surgery.
Thank you, Dr. Luchtefeld. Dr. Hopp or Dr. Wright, would you like to add to anything that Dr. Luchtefeld has mentioned?
Sure, I completely agree with him. The focus has shifted to a prehab approach for us as well. A lot of the general surgical principles apply with trying to decrease smoking as much as possible, especially for women that are going to have larger procedures, mastectomies and breast reconstruction. It's extremely important for their healing and their to try and decrease wound complications if they're not smoking. We do have the time frame aspect as well. And so still trying to encourage that is important. And we've been doing better with the resources on that. We do more in the last couple of years with the prehab program, if you will, with our rehabilitation team, doing preoperative teaching on scar massage and stretching and things they can do after surgery to help recover people faster. Also, as part of that, they get education on lymphedema and what to watch for and what that means, and they'll have follow-up appointments with that. So patients have had really good feedback about programs like that since we've started it. Very often in the office, I'll see people post-operatively and they say, well, I'm doing the stretches, I'm doing the things that they taught me how to do, and it's helping a lot. And I don't know this data for a fact, but it seems like people also say, I go to that instead of to my pain medication and see if it helps. And if it helps, maybe I cannot take that, as much pills on this, for that particular thing that's going on in the moment. And so I think it's helping them feel empowered to take control of some of those symptoms with that education. So it's been a great thing to see.
And I would echo what Dr. Hopp and Dr. Luchtefeld had to say, and also just take this time to appreciate Dr. Edlund and the rest of the staff at the Surgical Optimization Center, where we've sent a lot of patients for major operations to help make sure that all the T's are crossed and I's are dotted, and that if there is anything that's modifiable before surgery, that they do their best to address those things. And really, patients have just gotten a nice comprehensive workup there. And I think that's been a great addition to the health system in general. Dr. Luchtefeld pointed out, which is the same problem that we often have, is that some of these things are time sensitive, and so we don't have the ideal time frame to be able to address all of these issues. But there's good evidence that even stopping smoking 2 weeks before an operation can improve outcomes. Same with getting blood sugars under control for patients who are diabetics. And so there are some things that we can do that can make a difference, and trying to make sure that we're focusing on those things at the right time rather than dealing with the complications afterwards has been really important. One other thing that when I read this question, I was thinking about the opioid epidemic, and some of the issues that we run into after surgery with prescribing pain meds, some chronic pain issues and things like that can arise. Certainly, we've shifted our mindset on that, and we're looking to use opioids a lot less than we have in the past. We know that they're toxic to the body and they cause problems from constipation to mental status changes and other things. And so we're trying to utilize non-opioid pain medicine and techniques that can help with that. One great example of that is for mastectomy, where if you go back not too far in the past, that was a couple days in the hospital with adding we call regional anesthesia, where patients get sort of a nerve block beforehand, and sort of maximizing the non-opioid pain medicine. The vast majority of patients are going home as an outpatient now on the same day. And so that's been a huge shift in practice. And I think is better for patients overall. But we need to do our job of preparing patients for what they should expect, because certainly people go into an operation with expectations, and sometimes those are accurate, sometimes they aren't. And so making sure that we're framing those appropriately so that patients know what to expect, so that they know to expect to go home the same day after a mastectomy, and what they can do to help with some of the pain, using ice, using other things that might be of benefit. The more we can do with education before surgery, I think the better off we are, and the more smooth transition to recovery afterwards.
Paul makes a great point about the opioids, and I would certainly say that I agree with his comments about the Surgical Optimization Center. They do really a great job there. For the opioids in colorectal surgery, is particularly important because we know that they really affect the gut function after surgery. And we looked at this a couple of years ago, and we found that actually of our patients undergoing major abdominal surgery, a full 25% were already on a narcotic when they came to the hospital, which really complicates care. So the opioids are a big part of the problem in terms of trying to get people out of the hospital in a reasonable fashion.
Excellent. All very good points. Thank you. We'll queue up the next question for the panelists. When should someone contact their primary care provider to address any of the side effects that you mentioned?
I think certainly, early on after surgery, within the first few weeks, I don't think many of us would expect a lot of that burden to fall on the primary care providers, and that a lot of that is initially at least directed through our offices, and to sort of troubleshoot these issues. And as we come across these side effects or complications, being able to direct people to the right person is usually easier, I think, coming from the surgeon who did the operation. And some things may or may not be related to the operation. And so part of it is just sorting out some of those details. Certainly, I think as time goes on and patients get farther from the operation, that's where we need to partner with the primary care physicians and making sure that we're dealing with things, chronic pain being maybe one of the biggest things on that list, but other lymphedema, as Dr. Hopp talked about, is kind of a later complication that's often seen. And so, I think from my standpoint, our office wants to continue to be engaged as things arise, and so that when patients do contact their primary care providers, if there are any questions, I think keeping the dialogue and communication open so that we make sure that they have all the resources they need and to help address those things is very, very important.
Yeah, I would agree in the acute phase of their treatment and everything. We really do encourage our patients to reach out to our office. A lot of times we very quickly can say, yes, that's normal, and maybe avoid some unnecessary phone calls for the patient and even unnecessary imaging sometimes with reaching directly out to our office. And we, as far as breast cancer care goes, they rotate very frequently through surgeon's office and medical oncologist's office. So a lot of these things should be directed our way. And I really would like to encourage patients to contact us. And even if it is longer after their surgery, if it is a symptom they think is related, we can be of assistance in sorting out, is it something that needs to stay with our office or be directed back to the primary care doctor?
Yeah, same here for colorectal, in that in the immediate post-op period, we actually would prefer to hear about these troubles for the most part, and occasionally something very unrelated to the surgery comes up, and then we can get them directed to where they need to go. But I think most surgeons feel guilty and feel bad anytime anything goes wrong, and we take full blame until we can prove it wasn't related to the operation. And so for the first, and I don't know what the time frame is, but certainly anytime within the next month if something unexpected happens, I would say, contact the surgeon directly. And as much as we like to blame anesthesia and other providers, many times we have to blame it on the operation.
Yeah, I agree. And that, made me think of also something related to the last question. The things that I think do pop up that might come through the primary care offices are things like leg swelling and things like that, which could be related to blood clots, after an operation. Certainly in terms of things that can be done from a prevention standpoint, being active, early ambulation after surgery is important for that. But some patients do go home and develop blood clots after an operation. For the major operations now, we usually send patients home on a prophylactic dose of a blood thinning medication to prevent that within the first 30 days. And that has decreased the rate pretty significantly. So it's relatively uncommon. But those are the sorts of things where when those do happen, it's probably something that both the primary care physician and the surgeon should know about, because whatever medication treatment is needed or prescribed is something that might end up being managed by the primary care physician, and certainly something that now is part of that patient's history that they should be aware of. And so that's one of the things, at least in these major surgeries, that we come across.
Thank you. And we'll queue up the next question. And this is a two-part question. Are there any lasting side effects that patients should anticipate prior to treatment? And if so, expand on what these are and how patients might cope with the long-term effects.
I think that there are, as much as we talk about side effects, with breast cancer patients, I think it's important to remind them, though, that not all of those things will happen, and setting up a reasonable expectation that tenderness, range of motion issues, possibly even lymphedema could happen, but that they shouldn't fear these things because they are rare. And it's all about setting up those reasonable expectations. I've even had, if we go too far with saying, with educating on side effects of saying this will happen, patients I've even had call and say, well, do I have to even have those lymph nodes removed because they're fearful of the 3 to 5% risk that they might have. So I do think it's important to talk about side effects, but particularly with breast patients, I try to talk about them, educate, but not emphasize that they will happen, and just more as education. And I think the same goes with management of pain afterwards too, just like Dr. Wright was saying. It's patient education based, and approaching it from that standpoint, at least within our specialty, I feel that's very important.
I can mention colorectal again, and in terms of long-term and lasting side effects, again, I'm going to separate it into colon and rectum. And for the colon, as Amie said, some education up front is really important. And when I'm discussing this issue with patients and they're asking about long-term effects, many times they're wondering about bowel function. And for colon surgery, segmental colectomies, what I try to emphasize is that there may be some short-term change in bowel function in terms of number of bowel movements and that sort of thing, but we really don't anticipate any long-term serious side effects that way. And even when we talk about taking maybe 25 to 30% of the colon out, like when we're doing a right colectomy or a left colectomy, that sort of thing, many times people will go back to close to their same bowel function. And even if it's not exactly the same, it tends to be relatively easily managed either with fiber supplements or some low dose antidiarrheals like Imodium and things like that. So that is something that we handle more on sort of a case by case basis, but I try to emphasize that it's generally not anything to be worried about in terms of a long-term effect. Many people worry about continence and control, and again, for a segmental colectomy, they should not end up with a stoma. They should not end up with control problems. So we can usually eliminate a lot of those fears for colon surgery, as long as we get through without any big complications that we change that. Rectal cancer, though, again, it's different. And I try to have the discussion up front that function will be different in most cases. And going back to those principles that, we're replacing the rectum, which is relatively large caliber, relatively stretchy or compliant, and we're replacing it with a part of the colon that's not as big a caliber, and it does not have the same sort of stretchiness or compliance that the rectum does. So you have a smaller chamber and one that doesn't stretch as well. And if you add to it radiation and chemotherapy, the radiation and chemotherapy we always try to do up front, but that does still affect not so much the colon that we replace it with, but it does affect the sphincter function. And so I tell people to just anticipate that they're going to have more frequent bowel movements, and they may feel like they don't empty well. And once and if they're in one of those people where that's really a bothersome problem, we have to just work hard with things like antidiarrheals, fiber supplements, and just getting people used to the idea that this is the way it's going to be. Oddly, there is a name for this. It's called the low anterior resection syndrome, but it's a well-described syndrome. And another thing that's a bit odd is that many of you may have heard of this InterStim, which is a sort of a pacemaker for patients with incontinence, for both bladder and rectal incontinence. And oddly, this InterStim can be useful for patients with low anterior resection syndrome as well. Nobody really knows the mechanism, but it does seem to help. So one of the important things to know about this set of symptoms is that typically it does get better with time. And that's one of the really important things, is just to emphasize, I know this is miserable, I know it's a real pain, but it does get better with time. And typically that length of time that it can get better will at least stretch out to at least 6 months, if not a full year. So even if you're not where you want to be at 6 weeks or 3 months, it typically continues to get better. And we do have different ways to deal with it. So I just try to give them some hope that it will get better.
Same on my frontier. Sometimes we do end up in certain situations where sort of very advanced cancers, we have to do these major operations, and sometimes those patients do end up having to have a permanent stoma, where stool is emptied out through the abdominal wall into a bag. And that can be a shock for patients to hear or think about initially, as they think about their sort of their quality of life as it is beforehand, and trying to wrap their mind around what it might be like afterwards. Dr. Hopp alluded to patient education, and that's where our job comes in, and trying to explain that just because you might have to live with a stoma doesn't mean that your quality of life will be poor. It's actually not limiting, or not as limiting as people might suspect usually. And so some of those things are challenging. But to Dr. Luchtefeld's point as well, we have some evidence with certain operations that we do that the quality of life does not fully return to normal until 3 to 6 months after surgery in many cases. And so I think preparing patients for a long recovery, and knowing that that first month or two is not what life will be like forever, and helping them navigate through that can be challenging, but is also necessary to make sure that they have their eye on the prize.
Thank you. And we'll tee up the next question. This also is a two-parter. Can you speak to the importance of surveillance after treatment and what role primary care providers should play in the process? And also in that, talk a little bit about how frequently patients should check in with their physicians.
So for breast surveillance after breast cancer treatment, a lot of that would depend on maybe what type of surgery they had. But for most women who undergo a lumpectomy for their breast cancer, they would be undergoing annual mammograms as they were hopefully doing previously. And we tend to follow our patients in the surgery office and the medical oncology office for up to 5 years, and we'll order those, the imaging during that time, as well as seeing them for clinical breast exams. During this time, I do encourage patients to continue having their visits with their primary care physicians. A lot of times they may say things like, well, I have a lot of these appointments and I haven't been, and I really encourage them to continue their maintenance care, because keeping their whole self healthy is extremely important in their cancer follow up and in their treatment process. And it's been helpful to develop survivorship programs for patients to understand what their surveillance should look like, so that they're educated about it, and so they also can inform their primary care docs what they're doing in that regard. And then also on our end, it's important for us to communicate to primary care providers, and we are transitioning those surveillance images and exams to their care.
For colorectal, there's some similarities there. And one of the things that we try to share with patients is that the first 2 years are when the majority of recurrences occur in colorectal cancer. Not all, but the majority. And so we try to touch base in some fashion every 3 to 4 months for the first 2 years, and every 6 months for the next couple of years after that, until we get to that 5-year mark. For colon cancer, it would be unusual to have recurrence after that time frame, although it's not unheard of. For rectal cancer, especially ones that have been treated with radiation and chemotherapy, sometimes the recurrence is delayed by that. And so we'll sometimes follow those people even longer. But I think for us, for both colon and rectal cancers, surveillance is lifelong after this. The timing of the surveillance decreases after 5 years, but we really have them try to touch base in some fashion a lot early on. One of the principles that we discussed at that time as well is that it just makes sense that if you can catch a recurrence earlier rather than later, your chances of treating that recurrence in any kind of reasonable fashion is much, much better if you catch it early. And so we try to emphasize that when we're asking them to come back either for blood tests or office visits or whatever. And certainly the primary care docs play a role here, because sometimes patients get our reminders and they forget about it, or occasionally there's human error on our side and we forget to send out the reminders. And so any way that they can help us keep on track is very useful.
Yeah, I would agree. I think there are some general principles that go across disease processes. In general, that is, surgeons typically follow for at least the first 5 years, I would say, as a general rule of thumb. For the types of operations that I do, follow-up ranges from anywhere from 3 to 6 months for most cases, to sometimes just once a year for early stage, less aggressive types of cancer. And so it's very much stage based in terms of the frequency of follow-up and what needs to happen at those follow-up times. From a melanoma standpoint, which is one of my interests, there's not great guidance right now on the best way to surveil patients over time. And so I'm excited about a trial that we're up and running with here, where we're looking at different ways in which we follow patients based on their risks of recurrence, and using not only their stage, but some genetic analysis of their tumors to help stratify them based on their risks. And so we're up and running with that, and have enrolled several patients that we'll be following here over the next few years per those protocols. And for things like melanoma, those are things that are often identified, recurrences are often identified by patients. They may also be identified by primary care providers. But I think just the knowledge of patient's history, and that if there is a lump or a bump nearby where they had their surgery, particularly for breast and melanoma, those are things that we want to know about. Certainly, as really everyone is at least at a small risk of having a recurrent process. And then, again, the check-ins are really based on the disease and what the stage it is.
Thank you. And at this point, I would like to open up to the attendees any questions that you may have for our panel presenters. And you can do so by raising your hand and we'll call on you. I see we have Dr. Al-Janati. Please go ahead with your question.
If I manage to unmute myself so they can hear me, I think that's contagious from Amie. Well, thank you very much for the info. I really appreciate you guys joining us. Just want to ask Marty to expand a little bit on the frequency of colonoscopies after curative treatment for colon cancer.
Sure. The fairly standard approach to colonoscopy following the colorectal cancer is to do a colonoscopy in approximately 1 year. And if that looks fine, then you can probably wait another 3 years after that. And then following that, if everything else looks good, not always, but many times you can go to a 5-year interval. I would add that patients are sometimes uncomfortable with going to 5 years because they want to keep getting checked up more frequently than that. Nobody really objects to checking more frequently, but many of the guidelines say that you can, if you've got a 1 year and then another 3 years after that, if those colonoscopies look great, then you can probably go to an every 5-year schedule. I should add that, once again, rectal cancer is a little bit different in regards to taking a look endoscopically. Now, here I'm not talking about patients that get their rectum removed and have a colostomy, but for people that have had either a local excision or a low anterior resection, one thing that's different about the rectal cancers is the chance for a local recurrence. And unfortunately, CAT scan CEAs are important adjuncts to looking for recurrence, but a direct look for rectal cancer is really important. So for our rectal cancers that have undergone either a local excision or a low anterior resection, we actually have them on a schedule that's very similar to what we do for our CEAs. And in this case, the CEA, again, we're checking like every 3 to 4 months for the first 2 years and every 6 months after that. So our rectal cancer patients, we are seeing back and taking a direct look at the rectum every 3 to 4 months for 2 years, every 6 months. So they get pretty tired of getting looked at, I will say, by the end of their 5 years, and they're quite happy to be at the end of their surveillance for that.
Thank you.
We have a little bit of time for maybe one more question.
They're answering for free, so no charge. Encouraging people.
The one thing that we didn't really talk as much about was the role of our oncology colleagues here, like Dr. Alginati, because when I mentioned many of the things for surveillance and follow-up, I was mentioning only my part of it, but I got to say that in pretty much all these cases, we're working in conjunction with the oncologist. And so if I know that they are seeing them every 3 months, I certainly don't need to repeat the labs. I don't need to repeat the exams and that kind of thing. And so, you know, in terms of there being a captain of the team, I would say in the first couple of months, the captain of the team is the surgeon. But after a couple of months, the captain tends to be more the oncologist. And so I would say, at least in my specialty, we tend to take a little bit more of a backseat to the oncology team after that first couple of months.
Yeah, I would agree with that. I think I usually describe it as passing the baton. So, you know, we're all running the race, and oftentimes we pass the baton to whoever's running that leg, and it does change from time to time. But certainly working together as a team is important. And that's one of the things we've looked at for breast cancer patients. That's been a recent change over the last year or two, where we felt as though the surveillance was probably overdone. And so from a medical oncology standpoint, because they're usually getting anti-hormonal therapy or some sort of chronic treatment there, they usually are seen twice a year. And so the surgeons, we've reduced our follow-up to once a year to try to reduce the burden on patients for sort of excessive follow-up. I always, you know, tell them a little bit of redundancy is probably good the first couple of years, but for certain things. But certainly we don't want to be overburdensome if it's not going to be helpful.
Yeah, I think that's been really helpful to try to decrease that a little bit. And once patients understand that there is a sweet spot with that, they're okay with it. And we do, I feel like we do a very good job explaining to patients kind of which issues to bring where. They know if there's a change in their breast exam and they may need imaging, that they tend to call us. And then if there's systemic therapies, they tend to know where to direct those questions. So we have a good balance and a good teamwork there.
We'll open it up for questions. Any last minute questions from the attendees? Okay, well, not seeing any questions either in the chat or with anyone raising your hands. I want to thank all of our panel presenters today on providing us with exceptional information on managing the side effects of surgery and survivorship. Thank you, Dr. Amie Hott, Dr. Marty Luchtefeld, and Dr. Wright. I can't tell, Dr. Alginati, do you have your hand up, or is that a legacy?
Oh no, that's that's an old one.
Oh, okay.
I
all
get
right.
tired.
Didn't want to miss that.
Okay.
Okay, so thank you all for attending the symposium today. Please log in tomorrow to join us on September 23rd. To hear from our speakers, we have 2 topics tomorrow. Cancer rehab, Aaron Barris will be presenting, and lifestyle medicine, culinary medicine with Dr. Christy Arts, 2 additional topics in cancer survivorship. So with that, once again, I want to thank you for the time with us today and look forward to seeing you tomorrow.
Thanks for the opportunity.
Thank you.
A reminder on the screen about text recording your attendance. Thank you.
Thank you, Jerry.